who have not done these things before, serious implications of mental health, and then looking after our colleagues who are working in these stressful circumstances. So this is the hospital I work in, this is the emergency unit, and this is a 7-story building, and the top 2 floors have been converted into COVID areas. And then on 3rd floor, we've got ITU and cardiac intensive care, which has also been converted into COVID cohort areas. 5th of March is specifically stuck in my mind because that's when we realized that in UK, COVID is going to be an issue, and specifically in Wales, where I work. And I thought, as a liaison psychiatrist, what's going to be my role? And these are the challenges in the hospital for mental health staff, but also staff in general hospital. But then thinking of crisis and crisis management, and thinking of how we are going to respond. And the first instinct was sit with my team and talk about various things. And you would realize suddenly psychiatrists are out of their suits, and this is a very unusual occasion, and I'm wearing a tie today, but now we are in general hospital dealing with day in and day out physical health problems. And we talked about delirium, we talked about drug interactions and produced documents to help our colleagues. But then with my colleagues in Canada, Mehrul Hasnan, Intisar Bhai, who was also a participant somewhere, he would know Mehrul very well. Him and I, we worked on this document. I'm not going to go through this, but if someone wants to access it, it is on my Twitter. You can email me, I can provide it. But the summary is this, that we got to think of a preparatory phase, we think of an active phase, and then the recovery phase. And you're free to contact me, and I'll provide you with the information in that document. But then we started thinking about the stresses and moral injury. Frontline workers are facing longer shifts associated with some negative impact on their physical and mental well-being, and exhaustion coming through that. We are all very familiar with the long working hours as doctors. We've been through it, but something which we are unfamiliar with is the nature of what we are facing in COVID cohort. We don't know about treatments. There's so much of uncertainty around. There's so much of uncertainty around how we manage our non-COVID patients. For example, a 38-year-old patient who was underweight, and my colleagues in general hospital, in gastroenterology, they were struggling. They were literally wanting her out of hospital because they didn't want to be in that sense of hopelessness associated with that. And we had to huddle together and come to a management plan to help her out of hospital quickly. And then there's that moral injury issue, which is very important to think from our colleagues who are on the front line. So what is moral injury? I'm sure most of you know about moral injury, but this comes out from when circumstances we work in clash with our ethical, moral, and also the training values which have been drummed into us over a number of years through medical school and through our training and what we have been telling our trainees. The distress that results from feeling that guilt, and then also going through that difficult decision-making process where we can't involve the relatives, the near and dear ones, or the patient themselves about their treatments. Those are the issues that come up with the stress of moral injury. And then the issue around PPE, for example, working in hot environment in ITU or otherwise, going through talking to patients with masks, with shields in front and wearing those gowns, it's not easy. And I have, on regular basis, I go on to medical and surgical wards as my role in liaison psychiatry. The day I come back from wards, I don't feel like talking to someone. I want to protect my family from what I have seen. I'm sure some of you would have gone through that process as well. You want to protect your emotions. You want to protect your family's emotions. And above all, you want to give them a positive message about what's going on, that majority of people are going to get well. It is the decision-making process through difficult circumstances, which is going to be a tough one. And this lack of social support is very important. Some of you might recognize these people, but might not. One of them is my friend who works in Middle East in the intensive care and in PPE. And it's not easy to work through. Donning and doffing is easy to talk about, but the impact it has on mental health is an important factor to consider. So this friend of mine, Asif, my sister Asma, and then myself, but there are a number of similar examples there. I was communicating with our friend Intisar earlier. It's not easy to work through this, and it has got an emotional and psychological impact. Work through what we go through in terms of lack of provisions, family at home, protecting them, worrying about the family's health, but what should we do about it? Okay, so the factors that we need to think of are providing practical support, proactively identifying those who are suffering amongst our colleagues, and then developing an evidence-based prevention and treatment tools. So those are the three important things that we need to think of. But the good news is this: majority of them would just need basic needs fulfilled, providing of information, talking about support and well-being, and then psychiatric intervention would be only a few people who would need that sort of intervention, and only on the tip of the iceberg. But we also know that from previous outbreaks, SARS outbreak, that work related to trauma and lack of social support can result in significant mental health problems. Between 6%, different studies say different things, between 6% and 20% would need mental health support in the long run. So what did we do locally was looked through various documents and compiled, the psychological first aid by WHO, some other documents from various sources, and compiled this one-page document and circulated it widely in our hospital and in other places as well. It talks about simple things like staying in contact with the family, making sure if you have your own physical or mental health needs, you don't stop your medication, you remain in contact with your doctor. But importantly, news, don't go for fake news. Look for authenticated news and minimize your intake of news. I can't take credit for this piece of work. This is a web page from our hospital's intranet, where mental health well-being has been talked about, and a number of resources have been identified by colleagues in psychology department. It's a very well-resourced web link which has been advertised. And as a liaison psychiatrist, I've provided few slots to people who need mental health assessments in terms of psychiatric disorders, a few sessions a week. We talk to people that it's normal to have certain responses, certain normal emotions and certain normal physical responses. Feeling helpless, nervous, sad. These are normal responses. At times you feel like coming back and bawling your eyes out and crying, feeling tired. But when does this become a problem? It's the red box at the bottom, which we need to think of. All of you are aware of these difficulties that people might find as indicators to seek help, but it's these 5 or 6 points which are important, that if you start taking unnecessary risks, you don't want to be out of the situation, I need to do more, this is my war, I want to be in there. When you start saying these things and you stay in hospital and not take your breaks, that's where you need help. I'm telling you things that you already know about, but just to put a structure to everything. So what we did was, rather than looking at psychiatric scales, we provided the symptom checklist, simple symptom checklist, work with few people, including Brigadier Mohammad Rana in Pakistan, Nehru Husnan, and my friend in Scotland and one in India. We worked on the symptom checklist. And if you want to use this symptom checklist, please feel free to contact me and I'll provide this to you locally. Something else Public Health Wales did was that people need to look at their own risk assessment. You need to risk evaluate yourself and understand your individual risk and your environment's risk. And it's provided, it has been provided with some scoring, and you can work your own score, and then that leads to certain outcomes. This document is available on internet. If you want, I can provide you with a link. I'm not going to go through this now, but if need be, feel free to ask questions later. Prevention. So lots of things have been said about psychological debriefing. It does not work. One-off interventions from disasters, SARS, etc., they do not work. Early pharmacological intervention, one-off, does not work. Information alone does not work. It's the support that comes along with it. But some support in form of trauma-focused therapy at 3 months, some emerging evidence is coming through. Those of us who are in positions of leadership, like Iqbal Bhai, like Asad, Professor Rizwan Taj, those of us who are in positions of leadership, we can play a significant role by finding time, creating an environment that supports our colleagues, and preventing this inaccurate information distilling through. So leadership works. We have a role as a leader, as senior people in the systems, giving clear communication and SOPs and precautions is important. Supervision and support for colleagues is important. Finding time for your family is important. Talking about your experiences is important. I find a lot of solace in coming back from the wards and saying, closing the door in my office and saying 2 nafal of shukrana for coming back and protecting myself and my team. So it's important. What are the don'ts? Don't offer psychological debriefing. It does not work. There's no evidence behind it. There's no, don't offer any non-specific training programs. It should be backed up by very evidence-based work. Don't rush to offer direct psychological interventions too soon, because lots of people have their inbuilt resilience, and people we deal with on Frontline, they're very emotionally strong people, and God has given this special strength and position to help others and themselves. But those who need help, we need to screen them. Don't offer any unproven approaches to psychological treatment. Counseling has no evidence base. It should be goal-directed work that we should be thinking of. We did this work with the colleagues in Pakistan, Professor Muaddad Rana and his colleagues for Red Crescent. And then those who are identified with psychiatric diagnosis, we need to think of collaborative care approach, psychological treatments that are evidence-based, like cognitive behavior therapy, trauma-focused work, and looking at medication, but looking at a full biopsychosocial package. We know from our own work with occupational mental health that every pound invested in cognitive behavior therapy saves almost £2. So it's a very good investment to think of, and maybe some training packages around that would be quite important. A friend of mine who works in Canada is specifically working on cognitive behavior therapy in COVID times. It's an ideal opportunity for some research, mental health outcomes for staff who work in field hospitals, and also I'm involved in one of the other projects. We put in a bid for a grant for assessment of long-term consequences for health workers who have had COVID infection at 3 months, 6 months, and 12 months, how they come out with their biochemical markers as well as psychiatric markers. So in summary, impact on mental health on frontline workers is inevitable, but we don't know enough about it. It's all a guesswork at this point in time, what's going to happen. So we should look at what evidence is available to try and second guess what we need to do for them in specifically in COVID-related illnesses. It's important to minimize the psychological impact on the frontline workers. There's a strong role for leadership, and we should be thinking of those three things. Who are the people who need our help? How we can provide support for them, and providing some basic front-end information for frontline workers is important. With this, Waqar, I will stop. It was just a quick whistle through what we have done, what we have thought through, and what can be done, and we can think jointly to help our colleagues specifically in Pakistan and be guided by Asad and Iqbal Bhai and all our colleagues in Pakistan. I'll stop here now.
Thank you so much, Tayyib, for such a comprehensive presentation. Much appreciated. So before I move on to panelists, I will introduce all the panelists one by one, and they will talk about 3 to 5 minutes what they have done in their institutions or in their cities. And in the meantime, I see at least about 66 participants and about 14 panelists. So about 80 people, that's a huge number. Just want to mention, we have our colleagues from Bangladesh also on this forum right now, which is wonderful. We see folks from Azad Kashmir, which is great. And we have now from Quetta also, alhamdulillah. So I will start with first with Professor Iqbal Afridi, who is our first panelist. He's Dean of JPMC and JSMU, and is also Dean of Psychiatry for College and Physician and Surgeon Pakistan. He's head of Department of Psychiatry and Behavioral Sciences at JPMC. And of course, he's president of Pakistan Psychiatric Society. So Professor Iqbal, if you'd like to share some of your thoughts, what you are doing and what Pakistan Psychiatric Society is doing and at your institution, please. All yours.
He just had to rush to the airport. So I hope he remains connected. So he asked me that possibly he'll talk, but in case if he doesn't get connected, then he just conveyed a few things that I could talk. So I'll just wait for a while if he can get connected.
Or we can come back to him.
Or you can come back?
I'm now connected. I can hear you. Can you hear me now?
Yes, we can hear you. Good.
Okay. So first of all, I'm very thankful to all of you for participating in this important program. Especially, I'm thankful to Professor Waqar Azeem Sahab for organizing this and giving us such an opportunity to see the stalwart of psychiatry in different part of the globe, especially starting from Professor Avijit Javed Sahab and others. And I'm very thankful to Professor Tahir Tayyib for such a comprehensive talk. And if there is a problem in communication, I'll apologize in advance. But however, what we have done at Pakistan Psychiatric Society, I'm lucky that having a good team of people like Dr. Professor Asad and others, Asad Tamizuddin and Professor Mukhtar. So what we did that the COVID has not spared any person or any country. And we are also having a lot of problem because of these socio-economic problems. And so what we did, first we focus on the public awareness. In this regard, me and Professor Tamizuddin and many of our colleagues from different part of the country has started program in Urdu and other languages so that we can reduce, make them aware of the COVID problem because of the low literacy rate, there was a huge problem. People are not accepting this. And also we had some program that there is no treatment for this, no vaccination, only behavioral vaccination. That is, if we improve our behavior by focusing on the physical distance rather than social distance, and we encourage and coin this that the social connectedness should be encouraged, but physical distance should be maintained. And we also focus that the chronophobia, that is the fear as a result of the corona, people were rushing for the assessment and also for the tests. So there were the capacity of Pakistan was inadequate. So we had this information and awareness to public that there's no need to rush to that. This will in fact lead to further complication and you may get infected. So therefore, if there is no serious symptoms, so they should not approach to the all hospital. And because you all know that there was a problem in Pakistan that tertiary care center are overloaded because the peripheral system, the general practitioner system is very weak. So therefore, we had a lot of patients. So that was the component of public awareness. Then we thought that the ongoing training of our postgraduate, that is FCPS and MCPS and MDs are ceased. So what we did, we started program at every institution, and we have done 2 programs. And we thought that one program should be from Pakistan. That is the speaker should be psychiatrist from Pakistan, and another should be Pakistani working abroad, and he's authority in the subject. And Tayyib Bhai will endorse that first program I did, although that was the initial program. And then later on, the second program, we requested Professor Asim Shah from America, and he did very well program. That was uh, uh, the touch deprivation or touch starvation as a consequence of the COVID. So that was a very well attended program. So now the next program we requested Professor Mohadat Rana. He will be talking about psychotrauma on Saturday. So in this way, and this was just not a formal lecture, but an informal talk. And we also did pre-assessment component, post-assessment, and in the meantime, we had spared 10-15 minutes for the uh, developing a skill, so that those things which are cannot be learned from books. So that component we inducted in that program, in 1 hour program. So I mean, we have developed our own group of the postgraduates so that they can ask question and so on. So that was the teaching training program. Then the third was the research. So what we did that we started to research locally. The one is there were people who are reluctant to wear the mask. So that was one why they are not doing, whether they due to their weight or their asthma or what is they're facing or suffocation. And the second was the coping strategy that is going on. And the third, which I want to especially mention, and with the efforts of Professor Afzal Javed, he's our mentor, and he uh, had a vital role to make Pakistan Psychiatric Society in Pakistan on board of co-fit study, which is collaborative study which will conducted is going on in many countries, more than 200 researchers. And that is, we have translated the website because the other languages were there, but Urdu was not there. And now we are working on the translation of the actual survey. And apart from that, we have developed and also helpline we have started. Helpline because we, when conducted a study, that people are not aware. In Jinnah Hospital, we took 100 person who are coming to our department. Most of them have not heard about WhatsApp or Zoom or Skype. So therefore, we thought that first of all, we will start helpline with simple telephone conversation. And that we started, and Professor Tamizuddin has already started. We discussed that. So therefore, that were the another things which we have started. And at the same time, we had developed with the policymaker. Yesterday, I had a very good meeting, and Professor Rizwan Taj, who is sitting, he played a vital role to develop a system and convince the policymaker, the minister, the secretaries that uh, without the involvement of the mental health professional, they cannot defeat or at least cannot fight against the COVID. So they now, I think one of the I always say that COVID has given us an opportunity that the positive aspect of COVID is this, that the environment is improving, and similarly the recognition of mental health has been done. And another thing that there is a single or global thinking that they should invest on health and education rather than on just atomic bomb or other things. And the other thing that the safety or the is connected of one country to another country. So therefore, global thinking should be emerged, and we are very thankful that now the minister has given us, with the help of Professor Rizwan Taj, that we made a policy for them that how the frontline professional the stress can be reduced, and conducted some one program by Professor Asad regarding psychological first aid. And and now the government has asked the Pakistan Psychiatric Society. He mentioned especially in front of the Prime Minister. We wrote a letter to the Prime Minister and also to the World Psychiatric Association President that prisoner the COVID aspect of prisoners should also be not ignored. So and Professor Afzal Javed will bear with me that we have written to them, and they have recognized that this component should also be addressed. So in this way, we have done the public awareness, the teaching training program for the postgraduates. The third is the research participation research, and the fourth is the convincing the policymaker that now they have given us a task with our request that we will develop a program to enhance the capacity of the general practitioner by integrating psychiatric component in the primary healthcare system, so that post-COVID we will have a lot of patients coming to our tertiary care center, and once we equip the primary physician, so therefore we can control that uh, uh, overload of patient. With this, I am very thankful to all of you, and I have best wishes for all of you, and let's pray for all the globe that we should be able to combat this menace. Thank you very much.
Thank you so much, Professor Afridi, for such a comprehensive overview of all your efforts from PPS in Karachi and all over the Pakistan. Wish you a very safe flight back to home. I know you're on your way to airport. Wish you
Thank
very
you very
safe
much.
flight. Thank you so much.
So thank you very much. Thank you. I am
So next we have our second panelist is Dr. Zila Qayyum. She's a training program director for Child and Adolescent Psychiatry Fellowship and medical director for emergency psychiatric services at Children's Hospital, Boston. And she's also on the faculty of Harvard and Yale both. So welcome, Zila from Boston. All yours. If you'd like to share what is happening in Boston. Zila, are you there?
Can you hear me now?
Yes.
Okay, perfect. Thank you. Assalamu alaikum. So it's an honor to be amongst such esteemed colleagues and panelists. I wanted to touch on two things, and I didn't want to be repetitive of the things that have already been said. So I know at Boston Children's, we were very fortunate that we, for over a decade, have had the Office of Clinician Support that has been there for individual and group support in cases of adverse outcomes, patient deaths, difficult staff interactions, difficult patient and family interactions. So during this time, they've really stepped in to check in with the frontline staff, even proactively just lending support. And then our psychiatry residents and fellows took it upon themselves to get involved in providing peer support for the other trainees in the hospital. But I think the part that I wanted to talk a little more about was that I'm also a reservist in the United States Army, and I was deployed to New York City to a community hospital with the Army response in support of COVID. And I was in a community hospital that was completely overrun, which I believe is what's going on now. So I thought that I'll let you know what my experience as a frontline physician was in that emergency room and what happened so that it might give points for intervention. And so I think the thing I remember was that this was an under-resourced, underprivileged population to begin with. And the day we walked in, there were the ICU was full, the PACU was converted into an ICU, and then there were 60 people waiting in the emergency room for COVID beds, which I think is kind of the situation that happens in densely populated areas. And I think what was helpful was that even when we were getting started, there was a lot of basic information that was pushed out to us by the leadership about COVID-19. What are the treatment protocols? What should we expect in terms of the stress and burnout? And then we, as a team or a group, were assigned so that we will be constantly or informally checking in with each other. And now that I'm back from New York, that group still sort of gets together, and it's not like psychological debriefing. It's more that we all work together. We had an experience together. How's everyone doing? And it sort of maintains that sense of connectedness that we still sort of talk about every two weeks or so. And the things that have sort of come up have been that we had a very high number of patients, and where the ED staff were intubating, 1 or 2 people per shift, now there were 9 or 10. There were a lot of patients crashing at the same time. And even though I know Dr. Tayyab sort of alluded to this, that the frontline workers are very resilient people. Death and suffering and excessive acuity is not new to them. But the sheer volume of what was happening, that was definitely new. And even though that, the recovery statistics for COVID-19 are fairly good, but when you are in, a tertiary care setting where you're getting the sickest of the sick and a lot of people are dying, it is very hard to look at the person who's struggling in front of you as just another statistic. And the numbers in the exposure of a single person are much more than they were usually used to. And people that you sometimes think that they were doing okay, they declined very rapidly. And so the psychological or moral injury that was alluded to before, this was very real. The staff were pulling out their own phones to help patients have FaceTime with their family. But when there were a number of patients crashing in the emergency room all at the same time or in the ICU, they didn't have that ability. And unlike other illnesses where family members are present, this was not the case for COVID-19. So we were tasked to make phone calls to families for the very first time, letting them know that their loved one had died. And this had a significant emotional toll on the frontline workers, where they felt they could have done more, or the chaos in which they were responding and working may have contributed to the deaths of the patients. So there was a lot of guilt because they were just, the resources were getting depleted. And then there were other people who just became very numb with everything that was going on. Another thing that I personally experienced and was interestingly brought up in our discussions was how the frontline healthcare workers who've seen the suffering and the death and the disease burden were faced with COVID-19 conspiracy theories, or the virus is not that severe, or people are very, very dismissive, or they weren't wearing masks, or the first question I got asked was, is this really real? Is it as severe as they say that it was, or is this all just hyped up? And that in itself can be very demoralizing and invalidating for the people who are out there putting their lives at risk every day. And to put it simply, I think the 5 areas that we identified that we needed to work on was the need to make sure people were heard, that there were proper channels of communication, that people were being adequately protected. So we knew where the PPE was, there were proper trainings for donning and doffing, and how are you prepared? And I think that is, probably the biggest take home point, and I know Dr. Tayyab sort of alluded to that as well, is that there are no real solid evidence-based guidelines at this time. We're winging it. And knowing that there will be novel challenges, there will be decisions that we will be making that we haven't made before, and everyone is in this together. The burden of responsibility has to be shared and not put on one person up on the front line. I think that kind of intervention is sometimes very helpful, particularly when the leadership sort of owns it as well. And then the need to have people feel supported, whether it was with basic things like the medical students at Harvard Medical School, because they were all on virtual education, they banded together to provide childcare for the physicians over at Boston Children's. And then the need to feel taken care of, which is that if I get sick, am I going to be okay? Is my family going to be okay? And that's where the institutional culture and people stepping in to provide support and the institutional support for simple pay coverage were things that we hadn't anticipated would become challenges, but once they were addressed, I think really went a long way.
Thank you so much, Dr. Zila, for sharing your experience. I saw your picture in all the PPE and your wonderful article you wrote, the newspaper. I think it's worth reading. If you Google, you can see the article she wrote about her experience in New York, and everybody knows what New York have gone through, probably one of the most busiest places. So thank you so much for your presentation, and thank you so much for your service. Much appreciated. Thank you. So moving along, and in the meantime, as I'm introducing panelists, if folks wants to put questions, that would be great, which we'll take at the end. So next we have Professor Rizwan Taj, who is head of psychiatry department at Pakistan Institute of Medical Sciences, is Dean of Medicine and Allied Health, and he's principal and chief executive of Federal Medical College. And he's doing a lot of work with the ministry in Pakistan also. Professor Rizwan, all yours.
Right. There are a lot of things happening at the moment at the top level, but I'll just focus on the topic that is the frontline workers. Now, PIMS is the front of the Ministry of Health of Pakistan, and it's the best funded hospital, and it has all the equipments and the PPEs and everything else. The issue at the moment is that even though we have all the protective equipment and everything else, about 130 of our staff have shown positive for corona, which is very distressing for the frontline healthcare workers. The second thing is that the space created for the COVID treatment areas, there was no trained staff as such. So what they're doing is they are rotating all the doctors except from OBGYN. All the doctors from all specialties are rotating, providing treatment to the isolation wards and isolation centers. Again, that's a very big burden because they're actually not trained for that purpose. And they really haven't advertised new posts for this kind of work. Then the workload has increased that we had initially had 10 patients about a month back. At the moment, today, we have 53 serious inpatients. And we have an outpatient filter clinic covering about 250 patients daily coming for tests and advice. At the same time, when we talk about the workers, we forget one thing, one issue which is probably unique to Pakistan is the violence and the aggression that they are facing from the relatives and even from the patients as well. Again, that's a big issue. And again, all this in combination is exhausting the workforce, and that workforce is very precious and it's causing morale and resilience issues. So what the Ministry of Health has done in terms of mental health is that they decided 1 week back, they decided that they would have a two-month plan in which they will have sessions for all the frontline staff, and they gave a number of say 15,000 all over Pakistan. And they're going to have training in stress management, de-escalation techniques, and caring for carers and everything, a lot of other topics as well. So it will be a 2-hour session. So that started yesterday where Professor Afridi was there as well, and the minister later joined us. Again, when we went through the training, we realized that most of the staff have no idea about mental health issues. So again, a very serious matter that knowledge about mental health issues is completely lacking in the frontline staff. Then we were asked that we should have helplines, which Iqbal also spoke about, on telephonic helplines. So we have had one in PIMS for the last 2 months. It's working, but the response is maybe 5-6 calls a day. And the first thing when they speak, the workers, they say, we do not want to be identified. We want you to tell us, share our problems with you, but we don't want to be identified. So we are okay with that. That doesn't bother us, but we are just to give you an idea. So what I'm trying to tell you is that this issue about mental health, morale of and mental health of frontline staff is very serious matter, and it's going to become worse as the numbers again peak. As we heard yesterday from the minister, that he expects that the numbers are going to double maybe in the next month or so. And of course, there's a large population of patients we really don't know who are positive and out there, and they have never been tested. So all this is going to cause a lot of pressure on the health services. And remember, at the same time, we have a patient load of general medical issues. We were catering for 8,000 OPD patients a day. Our OPDs have been closed. Our elective surgeries have been closed. So there's a large population of general medical patients, non-COVID patients, who are roaming about and they have no place to go. And even the private clinics are closed, and the hospitals, I'm sorry to share with you, the private hospitals have found this to be a good financial, how shall I say, incentive for them, that they have started treating COVID patients. And they are charging, I cannot even tell you the figure that they are charging per day for treatment. So again, they're not carrying out elective procedures and everything else, but they've started, the private sectors have also started COVID-related work. So all this, is tremendous pressure and on the frontline staff at all levels. But let us not forget about the administrative staff. Now, to tell you, the Ministry of Health has been working 7 days a week, 10 to 12 to 14 hours. And they were saying that we are also under pressure. And again, the hospital administrative staffers are also pressured. So they would also be included in the frontline workers. And they've been working and preparing documents. And they have been trying to document each and everything from labs to facilities to ICUs to these ventilators all over the country. And it's not an easy task for a country like Pakistan, where devolution exists. As you know, every province works independently. So it's a big, big problem for them. So I appreciate your topic, and I tell you that this is very much needed. We'll accept all the help that we can get. For the moment, Asad is going to be looking after Punjab. Ghulam Rasool will be looking after Balochistan. Dr. Iqbal Afridi for Karachi and Sindh. And there will be Dr. Khwaja Ahmed in Kashmir and Dr. Mukhtar in Peshawar. Thank you.
Dr. Waqar, you're on mute.
Dr. Waqar is on
now, I think. So next we have Professor Ghulam Rasool, who is Professor and Head of Department of Psychiatry, Bulan Medical College, Quetta. He's a good friend. It's always wonderful to see some other cities than some of the major cities in Punjab and Sindh. So it's great to have Quetta's representation in this webinar. Dr. Ghulam Rasool.
First, thank you, Sir Waqar, for these nice words. Thank you for all organizers who arranged this program. I think all the hard work behind this activity is appreciated. The issues as described by Professor Rizwan Taj Saab, they are the same here in Balochistan. We have here different problems which already he discussed. The one thing which is most important, which I adding with his statement, is the patient who are the previously suffering from psychiatric illnesses, and they are living at their places abroad from the Quetta. They have facing issues of consultation because there is no well organized IT with them. They have issues of the drugs, and their previous illnesses has emerged or precipitated. This one issue is here. I think the same issue will be with all provinces too. We have started services online. We're giving all services, inpatient and outpatient services to any psychiatric patient here at institute. Almost all consultants of Balochistan have started their online consultations for the patient, and those people who have some issues related to COVID. At the same time, we have started training here. At least we have, I have covered 5 activities of training the social welfare department and UNICEF for the training of the frontline people who are social working in different isolation centers and quarantine centers in different districts. At the same time, we have giving stress relaxation techniques, different techniques for the doctors and the frontline doctors. While some different patients from the isolation centers and some from the ICUs, they have directly contact online with us, and we give different consultation for them, psychological as well as Zoom. If they need some medications, we give medications also. So the things are equal throughout Pakistan, the same, and we are trying to help the people. Like the people, the PPS activities already Professor Iqbal Afridi sir has described, and we are also active participant, one participant of those all activities. So at the same time, HSC have started a program for the students of different universities, faculty, and at the same time the administration. So that activities are in pipeline, and we will execute in the inshallah when the program will be finalized. The same in the same activities, Professor Modat Rana and Ali Shah Saab is also part of that activities. So we are going to help the people, and at the same time the patients who are suffer from mental illness, the old one and the new one. Thank you.
Thank you so much. It's great to see all the work you're doing in Quetta. So Quetta is not behind any other cities, and Balochistan is not behind any provinces in Pakistan. Thank you so much. So next we have Dr. Finza Latif. She's Training Program Director for Child and Adolescent Psychiatry Fellowship and Director of Child and Adolescent Psychiatry CL Service at Sidra Medicine, and she's my colleague in Doha, Qatar. Dr. Finza.
Thank you so much, Dr. Azeem, and Assalamu alaikum, everyone. It's really great to hear what's going on everywhere, and especially in Pakistan, so this is wonderful. So at Sidra Medicine, basically in early March, colleagues and also my trainees reached out to us to say staff is stressed, and unlike Boston Children's, we actually don't have a clinician support team that was in existence prior to this. So we decided that we needed to put a work group together and think of how we're going to provide support to all of the frontline staff in the hospital, but also the non-clinical staff who were equally experiencing distress through the pandemic. So what we did, we initially did a really quick literature review of impact on hospital staff from prior pandemics, Ebola, influenza, SARS, and then we created a survey that asked our staff questions about the key emotional distress symptoms that were experienced in previous pandemics to get a needs assessment. And we actually saw that a majority of our staff were experiencing some of the things that everybody's mentioned: guilt, moral distress, but as well as anxiety and depression. So we have created a tiered mental health support model, which is actually something that some hospitals in the US has also put in place. the premise really is that most of the hospital staff are not going to require individual cognitive behavior therapy or psychiatric management. So the base of the intervention is really putting together curated web content about how to manage stress specifically for healthcare staff. And that's available on our website through our hospital portal. The next level up is all of the psychiatry department staff are volunteering to provide educational webinars that are available hospital-wide and will be available as recordings. Topics include stress management, trauma, grief, burnout, all of the significant issues that staff are facing. The next level up is peer support groups. These are much smaller groups, 8-member groups, which are led by a mental health provider. And these are really for specific frontline staff, for example, ED staff, nurse managers. I'm going to lead one with Dr. Waqar, hopefully, for pediatric residents. And what that is based on, some of you, if you trained in the UK, you might have heard about the Balint model, or in the US, it's called Schwartz rounds, which training directors are familiar with, which, just discussing a stressful clinical situation, which in this case would be COVID related. And then the final tier, of course, is the smallest, the people that we would expect require individual cognitive behavior therapy. Right now, Qatar actually has a national hotline, which anyone can call and request a mental health assessment, and through that be connected to an individual psychologist or a psychiatrist. But Sidra will also be offering use just for Sidra staff, individual cognitive behavior therapy, trauma related and related to COVID. So that's basically what we've been doing, and we're, hopefully we'll be able to get results from the we have results from the pre-survey, but 3 months from now we're planning to conduct a post-survey to see what was helpful and what do the staff need now, 3 months post-pandemic.
Thank you so much, Dr. Finza, for your contributions, not just for this webinar, but for Sidra and for Qatar. And of course, some of our panelists are already spoken with, like Asad and Imtiaz Dogar, doing the same survey what we're doing over here, that we can replicate some of those things in Pakistan also. Thank you so much. Next, we have my good friend, Professor Imran Ijaz Haider, who we saw with our whole team in Lahore just a few months back. And he hosted us very well. It's always wonderful to have him and Dr. Nazish supporting all the needs, especially in Lahore and King Edward and Fatma Memorial Hospital. He's professor and head of Department of Psychiatry for Fatma Memorial Hospital, and we'd love to hear what kind of things you're doing in your hospital and in Lahore.
Thank you very much, sir. Always wonderful to have you also. We will be forward to see you next year also. With regards to the COVID-19, I think all the panelists have said mostly the things which we are also doing in actually privately are the same. It's on the institutional basis. We are trying to address the issues from the doctor's point of view and from the student's point of view. From the hospital point of view, we have made a strict policy that only one patient comes along with one attendant, and they are being screened, and there is a system of a triage before the patient enters into the hospital. And I think that is all the reason.
Professor Imtiaz, you have to mute your mic.
Sir,
Sorry, Professor.
So, no, that's okay. So we have to, we are still seeing the patients, and the influx, as Professor Rizwan Taj was saying, there is a great influx in the government hospitals, and the government hospitals are not taking. So the influx has been directed towards the private hospitals now. So we are still open up, and we are seeing the patients. What, I was just hearing about from Professor Tayyib Tahir, actually, and he mentioned few things which I am very much inclined to also put across to my panelists. First of all, what we face, I especially facing from the doctors, is the fear. And second is the fear of death. All the doctors, they feel very fearful going towards the corona ward or to see the patients in emergency. How to address that issue? And like Professor Rizwan Taj was saying very nicely, that because the doctors are getting shot in the numbers and they are refusing to go for the duties, all except from the OBGY, all have been directed towards the corona ward. Now, how to deal with them, how to deal with their emotions as doctors. And somebody was just actually mentioning, I think Dr. Zila was mentioning that there is an element of stigma attached to it. Do you think that doctors should say that I'm suffering from a depressive illness? Does it, he has an ambiguity or ambivalence that one side is the duty because he's a doctor, he's been called to look after a pandemic. And on the other hand, how should he look after himself? And Dr. Tayyib was saying, how should he go back home and what to say to the family? The families are refusing. Unki wives, they are all saying, don't go to the hospital, don't go to, come home, don't meet the children. Some doctors are actually trying to quarantine themselves despite not having any symptoms. So counseling of the colleagues, the counseling of the families. So the issue of the duty and the morality is a big thing. We are trying to counsel the doctors, but sometimes it's very hard to sit down with them on a practical ground. It's very difficult what to say to them, to be honest. And as a psychiatrist and as a psychologist, we feel very, very difficult to answer their questions. Even some doctors have come up and asked, should they start an antidepressant? And I feel very difficult to answer that question, yes or no. In a way, I could say yes, but what should I, how long they should take for, what is it? So, and the issue of the info pandemic, like Dr. Zila was mentioning very nicely, patients, they still don't believe it that this coronavirus is something. They come and ask you, is it real? What to say about them? These were my views, which practically we are doing the same thing like we are doing in the different part of the country. But I think initially the start of the discussion I was having with Dr. Tayyib, we are facing more problems now here because this pandemic has really gone out of proportion and doctors are literally very fearful. That's my few comments I wanted to say. Thank you.
Thank you so much, Professor Imran, Heather, for sharing your experience and your thoughts. Much appreciated, and all the work you're doing in Lahore. It's always amazing to see. Thank you. Last but not the least, we have our young psychiatrist, Dr. Sadiq Naveed, who's in Kansas. He's assistant professor of psychiatry and behavioral sciences from University of Kansas Medical Center. He's a senior research fellow for Human Development Research Foundation, Pakistan, and he's also doing fellowship in infant mental health. And I know he do a lot of work in providing PPEs and other stuff with the Nishtar alumni in Multan. So Dr. Sadiq, kindly if you can share your actual experience, not just with this, but what you have done with the Nishtar also and your efforts in that regard.
Sure. Thank you, Dr. Azeem, for letting me and inviting me to be part of this esteemed panel. I will touch on different points. I think this is a public health epidemic. So what we really need here is a public health approach. So I would start from the community level, and I would say what we have done in Nishtar and also at University of Kansas, and what can be done in future. So one thing that is pretty lacking in this whole strategy to fight this pandemic is stakeholder engagement. So stakeholders involvement means healthcare workers, public health officials, community leaders, government officials. You cannot fight this war just by just treating patients who come to your hospital. You need voices from the community to fight this pandemic, who can carry the message to the masses, because a lot of it is about preventive measures. And as a community, we also have to think about it's not you versus them, it's us. So we did different efforts with NISTER. NISTER at one point was, we had roughly about 35 doctors who were infected and allied healthcare workers who were infected with COVID-19. And so we raised donations in the United States and some in other areas around the globe. And we provided COVID PCR testing and then amplification testing to NISTER. So they were able to test roughly around 200 to 300 allied healthcare workers and physicians, so they become part of the workforce again. Another thing that we were done, and that was earlier in the days where there was a lot of shortage of PPE, and we are still struggling to find PPE. We arranged some PPE from China and delivered it to NISTER. So, and in addition to this, there were some webinars for people in NISTER. So it takes more than just one person or government or hospital or doctors fighting it. It should be a community effort. So what we really need is stakeholder engagement. Bring all the parties on the table and ask everyone, what are your fears, worries? Because fear is one thing that disconnects our emotional brain from our rational brain. Our emotional brain is processed by amygdala that can cause a lot of feelings of fear, anger, irritability. So that's something that needs to be done beyond the hospitals, that needs to be done in the community. At the organization level, at the hospital, I think there should be a strong focus on education and awareness. So during early, alhamdulillah, we are doing much better in Kansas now, but when this pandemic started to appear and a number of cases were increasing, there were daily emails from the leadership. And I don't mean the departmental leadership, the health system leadership, about the daily updates, and all the staffs were being educated about the proper use of PPE. And then there was also the distribution of PPE based on CDC and WHO guidelines. So we knew what I can use if I'm working in an environment where I'm more exposed to respiratory secretions versus if I'm just doing some outpatient work. Second thing was communication, and communication based on openness, collaboration, and transparency. There were weekly town hall meetings, and some of those town hall meetings were within the department where all the faculty were involved on those town hall meetings. And then there were also town hall meetings at the health system level. One thing that we need to know and be careful about these town hall meetings is that we should believe in the mission of the organization. The purpose is to carry, as a healthcare organization, the purpose is to carry the message and provide services. So it's not a departmental leadership versus the allied healthcare workers or trainees. We all have to fight this together, and we have to address each other's fears. Second thing that was done was KU, University of Kansas, expanded its psychosocial support services. Our psychologists provided services to different healthcare workers who were needing any sort of psychological services. We also had change in our work environment, at least at department and outside of the department where services could have been provided to telehealth. Those services were shifted to telehealth services. And even if there were some staff who had high-risk family members, they were allowed to work from home. And at the interpersonal level, I think we all need to learn to lean for each other's support. So we need to regularly check with our colleagues and see if they need any sort of help. I remember in my hospital, so we are in a satellite hospital as part of KU Health System. Our 2 employees were positive with COVID, and their names were not revealed, but there were email communications that, you know, this happened. So there was communication, open communication, that we have some colleagues who were COVID positive, and then there were emails from the colleagues on the other side that if you need any sort of help, for example, grocery shopping, because you cannot leave the house, we are here for you. If you need some sort of financial support because, you know, you lost any financial revenue source, we are here for you. So, so fighting with this COVID as a community, and then at the last but not least, at the individual level, I think Dr. Tahir very eloquently mentioned different things that we can do, and I don't want to repeat those again. But I think my take-home message would be that we should fight this pandemic from a public health approach and from the community perspective, rather than just taking it as a healthcare problem. So we can fight it more effectively. That's all for me. Thank you.
Thank you, Dr. Sadiq, for your comments and your experience in Pakistan and in US. So I think might be good to take some questions now. I'm looking at some of the questions. Let's see. This is for Dr. Gila, and it is coming from Dr. Fauzia Chima. If doctors from specialists other than medicine anesthesia are being sent to COVID wards without prior training, oh, just disappeared. If doctors from specialties other than medicine anesthesia are being sent to COVID wards without prior training or inadequate training, isn't it obvious that their anxiety stress levels go up? If so, then what needs to be done other than just offering emotional moral support, not underestimating their importance? Thank you.
Answer that, please. As the situation is at the moment, there's really no choice, because there's no additional staff available, and there never was for infectious diseases specialty. There are hardly any specialist infectious diseases centers across the country. So they had to utilize the available resources. So I'm telling you that all my 15 trainees have done twice corona-related duties, and they had no training or no experience in that. But the things the thing in pipeline is that they are going to hire new staff, and they are going to hire doctors and nurses at all levels to look after these, and they will be properly trained. Just to give you an example, infectious diseases hospital has been set up within 3 months in Islamabad, a 220-bedded hospital. Now, the problem is that nobody is willing to take responsibility to run that center because there's no staff available. And to run a facility of that level, you need at least 1,000 recruitments, and there's no budget for that. So again, this was offered to PIMS to run, and PIMS said we're already overburdened. We really don't have the capacity to run another 250-bedded center. So again, that will take another 3-4 months before that center is fully staffed. So I'm just giving you an idea that unfortunately, this is the ground reality. We really cannot do anything else. As I've told you, all the staff at PIMS have rotated except the OBGYN. Thank you.
Waqar, can I say, training, I'm very fortunate to work in a system where there was a little bit of a warning and we could get training. I went and got some training because there was this possibility that I might have to work in some other areas other than psychiatry. But Rizwan Bhai is absolutely, he's hit the nail on the head. It's about who is willing to go and run this tricky situation. There is no timeline, and Sadiq Naveed is absolutely correct using public health as a message. At this point in time, it's important increase messages around social distancing, social isolation, which is not happening in Pakistan. Just now, one of the participants has mentioned another doctor has died, and we hear these messages of people going in and assaulting doctors, demanding. So public messages have to be really taken as a prime way of dealing with the situation. Doctors have to have breaks. We have to ensure that they take breaks, and it's where the leadership comes in, and strong leadership to say this is how you have to deal with, and demanding to work on the ground all the time from doctors who are not skilled to deal with this situation is very tough position to be in. But we as doctors, we are driven. We want to help people, but at the same time, we have to make sure that we protect ourselves, our juniors, and people around there, nurses and doctors, and other people working in the hospital. It's a very tricky situation, and lots of questions that people are asking. I can't answer, none of us can answer. We have to just go on and do as best as we can in this situation, and liaise with, and I'm sure Rizwan Bhai and Iqbal Bhai and Asad, they're liaising with the minister and everyone else up the chain.
Thank you.
Just to add a small comment to what the question has been asked. The issue is that I think Professor Rizwan and Professor Tayyab has already outlined, we have no options. The question is that who's going to come and work? I do understand that those who are not specialty oriented for infectious disease would have an anxiety, but I think the answer is the preparedness. So what we did at Rawalpindi Medical University, that when we were letting them to go into those duties, they all had a session learning about what this corona infection was, what they will do, how they'll wear the PPEs, and then we have a psychological first aid session for all those who went into this adventure. So I think the only answer we have is about preparedness, because this has no timelines, and we're not going to get any extra staff, especially trained for infectious diseases, who's going to work in there. So this is a problem, and that's the only answer that we have.
Okay, thank you. So I just want to add something. Actually, I was reading the comments, and I thought one comment is extremely important and very important for all of us participants and panelists, which Dr. Nasser Khan has, that how we stay optimistic in this situation, because it is very tough for everybody. And if you don't have some level of optimism, it will be very hard. Secondly is, as mental health professionals and as leaders, how you give some positive message. Like we all know it's going to end at some point. At what cost, we don't know, but it's going to end. And for example, I was talking with somebody, and he was sharing that with this pandemic, they have never spent this much time with the family before as they're spending now. So we do need to find some positives in all this. I think it will be very important for all of us. Not easy, but it will be important. I just want to say, Tayyab, you want to say something?
Yeah, Waqar, that's why I put the title as A Tale of Two Cities, because there are some of us who leave hospital and go and live in a hotel before they go home after taking a break for a week and making sure. So, and then there are some who will go in straight to home. So there are so many ifs and buts. Positive messages are very, very important, but falsely positive messages are going to give wrong impression to the public, wrong impression to our colleagues. Therefore, being truthful and honest in what we are dealing with is very important. But yes, it's important to give positive messages that 80% of people are going to get well. It's the critical end of the spectrum we need to. As a liaison psychiatrist, I am prepared to go and see patients with my colleagues in ITU or other places if there's a need to be, to support them, not to look after patients, but to support them.
Thank you for sharing. But at the end, I will still say this is going to end at some point. At what cost, we don't know, but this is going to end. I will just ask at the end Professor Afzal Javed to do some closing remarks. Professor Afzal.
Yeah, thank you very much. Thank you very much, Waqar. And as I said earlier, it was really a pleasure and privilege to be a part of this activity. Thanks to Professor Tayyib Tahar for setting the scene. And we had an excellent panelist from all parts of the country, from PAIMS, from Pindi Medical College, from Karachi, from Lahore, from Quetta. I think one thing we have to really keep in mind, although you are very optimistic that this will end one day, my feeling is that we will have to live with some type of residual symptoms, effect, or impact for our rest of the life. I mean, it's like one whole year has gone from this generation's life. But we are really pleased that there are so much work is going on in terms of what to do, what not to do, how to do. I just want to say 4 points, and these points are, what about the future? We will be, especially the mental health services are going to have a big impact during the post-COVID situation. Are we ready for that? Are our mental health professionals be ready for that with this change in our patients, in our clients, in our contacts, in our all those people who will be coming to our outpatient or inpatient? So this is one point which is very, very important for a country like Pakistan, where there are limited facilities for the psychiatric services. So that is one. And when we are trying to make a change, I would really appreciate what our colleague from Lister Medical College said. And I can say it on behalf of World Psychiatric Association that the next agenda for our next term is mental health should be practiced as a public mental health. And having this experience about the COVID, I think this is going to become an important aspect of our future practices. The third thing which I really want to emphasize, we have got experts from APNA, we have got local experts, international experts. I think Pakistan Psychiatric Society should develop a resource library on its website. We should try to put all what is available, which is good for practice, especially in our country, into that library. There are so many Pakistanis who have contributed and published papers during the last 2-3 months. This may be a sort of a very good effort on Pakistan Psychiatric Society's platform, that our trainees, our other doctors, our postgraduates, they are really in excess of all the information. For example, today, we have been given a number of good references. I think there should be a sort of a resource library. And I want to just emphasize that World Psychiatric Association, if you go to the website, we have developed a website, a COVID-19 resource library, and we have got the collection from almost 20-30 countries, what they have done, what are the good plans of action, and what are the recommended things. And then we have been talking about dealing with this problem, especially with the health workers. I tell you, this will come back to psychiatry. People will come back to mental health professionals, that how should we help and support our other colleagues or the frontline workers who are going to face or who are facing this situation. I mean, there may be many efforts, there may be many ways, many suggestions have been just put forward. Just to let you know that almost most of you know about a colleague, Professor Farooq Naeem, who is an expert in CBT. WPA is currently working with Professor Naeem to develop an online module for healthcare workers looking specifically at the CBT. So I think before someone else hijacks all these good things, our psychiatrist colleagues, our mental health professional colleagues in Pakistan should also start looking at what is going to happen in the coming years. So thanks, Waqar, once again. It has been a sort of a great exercise, and you and EPNA really needs a big appreciation, and we hope that we will be able to continue with all these efforts.
Thank you so much all for participation. Just want to mention in this series, our third webinar on supporting the frontline staff in a similar way will be on June 28th, same time at 8 o'clock Pakistan time. So thank you again. Wish you all the very best.
Thank you, Waqar.
Thank you. It's been wonderful.